When I inject the great toe, I give 2 injections, one on the medial dorsal and one on the lateral dorsal aspect of the toe. And I push right here, and then the needle goes in right here, just like this. And then I infiltrate the medication, and I'm pushing pretty hard with the pressure of the device actually on the toe. If I put good firm pressure, they feel essentially nothing except the medication going in. When I do this side over here, which is actually the medial branch of the dorsal, or the medial branch of the deep perineal, I use my thumb and I actually use that as resistance on this side, so I can actually push a little bit harder, and then I can put this right where I want it to go, just like that.
Okay.
So in this case, what I would do for a digital block of the second digit, I put the device directly on the top of the toe like this, and once again I give 2 injections, one on the dorsal medial aspect, just like this, and the second is on the dorsal lateral aspect, just like this. I've never had to use it on the bottom of the toe, but I guess that I could. With respect to a traditional neuroma, which we all know is in the third intermetatarsal space, what I typically do is I just put the device right where I know I'm going to go, just like this, and I push down. I'm actually pushing down, so I could almost leave an imprint on the top of the foot, but I push down with a little bit of force, and then the injection would go directly at the site of the needle itself. Occasionally people will fan the needle across when they do a neuroma, and in that case you would use the device right where the needle goes in, and then I actually move the device over where I'm going to push the needle where it ends up infiltrating the medication. And that way they don't feel the infiltration of the medication nearly as much. And so that would be for a neuroma. If the neuroma is done on the plantar aspect injection, it would be the same thing, just putting the device directly on the plantar aspect of the foot. Now, in this, let's say that this patient had a wart. What I've done in the past is I use the device on the plantar aspect of the foot, and I put the needle directly into the wart, and I infiltrate the numbing medication so that I can address it, just like this. And the harder I push, the less they feel, without obviously pushing too hard, and I can put it right in there like this, right on the spot. One of the things that I've noticed is when I push, even if I push hard, it doesn't change the cycles per minute of the vibration. So I'm barely pushing, I'm not even touching her, and I push it on and I push, it does not change the vibration. And I just go directly where the lesion is, infiltrate the medication, and then take it out. This could also be done if I were to do a plantar injection directly into the calcaneus, which some people still do, directly into the plantar fascia. And I've used this several times on people where I literally infiltrate or I push the needle all the way to the bone, back off just a little bit, and then infiltrate the medication. They do not feel the needle going in. They do feel the medication, but the sensation is considerably diminished using the vibration device. When I do a fifth toe, I put the device directly on the base of the toe, and I inject dorsal medial and dorsal lateral. I can also hold the device like this and infiltrate directly on the plantar aspect of the toe, just like that. And they don't feel it. Injecting the ankle joint, I know that the ankle joint is exactly at the level of the distal aspect of the medial malleolus. So I put the device right here, and I inject just like this. And I go right across the ankle joint, just like that, all the way across. Typically they do not feel at all when the needle is going into the ankle joint, but they may feel the infiltration of the medication. Going into the lateral aspect of the ankle joint, I know that the joint is 1.5 centimeters proximal from the distal aspect of the fibula. So I'm right at the level of the ankle joint, and I put the device on, and then I would inject right here, right at that point. For the perineal complex, if I were to inject in this area, I put the device directly on the perineal complex, and then I can inject right where the beam is at that point, right there, just holding it like that. With respect to the sural nerve, which we know is approximately 1.5 centimeters distal to the most distal aspect of the fibula, we know that it courses around the fibula at this spot right here. So if I want to hit the sural nerve, I can inject right here. And I know I'm into the sural nerve at that spot. For an intramuscular injection, let's say in the arm, the device is held essentially like this, a little bit of pressure, and then the injection goes directly into the site of the zone of anesthesia, just like that. When I do intramuscular injections, or if the nurses do it in the back, or if the back office nurses do the injection. The patients do not feel the needle stick at all. They only feel occasionally when the medication is being infiltrated.